For Dr. Yambao this time, regarding COVID myocarditis, is it just the standard of care that we give, or are there like specific medications that actually help the heart in this particular scenario?
By the recommendations and backed by the studies, the standard of care for heart failure should be given. But there are other management being given in patients that would also be beneficial, but although it's not supported by the randomized controlled trial. Okay, there are those, aside from the usual heart failure regimen, some would give colchicine because of its anti-inflammatory effect.
Yes.
Some would also give L-carnitine because it
Yes.
enhances the glucose exchange in the
Yes.
heart. And these are theoretically beneficial. It's just
Yes.
that no long-term studies were yet made. So these are like the adjunct treatment or supported treatment that we could also give to our patients.
Thank you, doctor, for that. So there really are several medications that have been shown, demonstrated in studies to be effective, and yeah, we can consider them as adjuncts in the treatment of our patients. For patients, Dr. De Jesus, if we plan to do a PCI in a patient, do we hold off giving streptokinase, or is it okay to give it and then as a bridge to PCI?
It's possible. It's what we call facilitated PCI, where we use streptokinase first if there's limited success, meaning there will be less, the patient's ECG will not have decrease in the S elevation. We can proceed with angioplasty even after streptokinase therapy. But again, these types of management, these types of strategy may increase the risk of bleeding in these patients, especially if you already gave streptokinase. So for these types of patients, we try to avoid using the femoral approach and use the radial artery approach, because there'll be an increase in the risk of bleeding if you use the femoral approach, because of the risk for hematoma formation after intervention.
Thank you, doctor. And there are some questions regarding the use of fondaparinux. Is it just like an alternate to enoxaparin, or are there particular scenarios where it would be preferable, or is enoxaparin preferable in your opinion?
Actually, they have equal benefits among patients, but we prefer giving, especially for patients who are about to undergo interventional PCI. We prefer the low molecular weight heparin, the enoxaparin, the factor 10A, because of its shorter half-life compared to the fondaparinux. So there'll be increase in bleeding if you if you switch from fondaparinux to heparin, the high molecular weight heparin, compared to low molecular weight heparin, the enoxaparin.
For Dr. Yambao, I think you mentioned this partly in your discussion, but there's a question here. Is there a role for a 2D echo, LV, or RV strain in diagnosing viral myocarditis?
Okay, the LV strain can also help in diagnosing myocarditis, especially if the patient's LV function is on the high side or normal. Or sometimes we may not see any wall motion abnormality in the usual 2D echo, and the LV strain can help us identify early onset LV or RV dysfunction. So it will help us diagnose, especially early onset cardiomyopathy. So in the institution where it's being also offered, so better to also request it.
Thank you. And for the doctors, if a patient goes into cardiogenic shock, it's not specified if it's ACS or from myocarditis, but of course both can cause that. What would be a better primary management? A volume hydration like bolus IV infusion approach, or immediately start with inotropic support?
An inotropes, either it will be a dobutamine or norepinephrine drip. But for me as interventionalist, it's also important for me, if it's an ACS, to revascularize the patient. You have to treat the source or the cause of the problem. Especially if it's an ACS, it's a reversible cause. So if you can reverse the thrombosis, remove the thrombosis that's causing the heart failure, and there's a bigger chance for the patient to survive the heart failure. But I think for myocarditis, it will be a different story, right, Ed?
Yeah, I agree with Dr. Jeff, because mostly patients presenting with ACS or myocarditis, they are already congested with volume overload. So usually I agree that we usually start patients on inotropes more than having a fluid challenge.
And I would just like to say that, well, first of all, actually, by definition itself, in cardiogenic shock, it already assumes that the patient has been volume loaded. I think the doctors will agree with me that the wedge pressure, by definition, is already elevated. But I'm just nagpapakapilos po lang ako. But now in our modern practice, there really are ways. If the question is just regarding shock, there really are ways in our modern practice that to know whether it's a problem of inotropy, or for example, if the cardiac index is low, or if it's a problem related to vasopressor support, if the systemic vascular resistance is low, and also if it's a problem related to preload, if the patient is volume responsive. So there are advanced monitors that can help us do this in our modern practice. And I think the standard of care is using thermodilution techniques, which we do in post-operative cardiac surgery patients. And I think also in very toxic post PCI patients, I think Dr. Des will agree with me. Yeah.
In toxic PCI,
Yes.
it's not only the use of pharmacologic inotropes. You can also put patients on IABPs, mechanical support,
yes, doctor.
VAD, and a lot of things you can use if you have the right toys in your lab.
Yes, doc. That's correct. We're only limited, doctor, by the available technology that we have. But
Yes.
but in the bigger hospitals, we really have ways of determining the precise dysfunction and intervening accordingly. So yung sagot po ay depende. Depende fluids, or as Dr. Yambao and Dr. De Jesus have mentioned.
The world moves in real time. So should our healthcare technology. With information needed, decisions to make, and experience to share, every second counts. Live integrated teleultrasound enables real-time communication, remote collaboration, confidence, knowledge, and learning. The first ever integrated teleultrasound collaborative platform. Philips Lumify. Integrated teleultrasound powered by React's collaborative platform. Innovation and you. Philips.
There's another one here. Is there actually a lower value limit before you give the antiplatelets? Like, is there a cutoff where you say, okay, we're not going to give antiplatelets in this patient? Or
these are rare instances, Armanda, but we've encountered patients who have leukemia, who have very, very low platelet, who had ACS. Very difficult to manage because leukemia cases, patients with blood dyscrasias have dysfunctional platelets. Despite having high platelet or very low platelet, their platelet function is very low. So there's always a risk for increase in bleeding in these cases. So maybe if the platelet count is less than 20,000, you might need not to do or give antiplatelets anymore, especially if there's an increased risk of bleeding. But in these cases, we've successfully still saved the patients by revascularization, just by using a plain old balloon technique or a drug-eluting balloon, just to open up the vessels. But I'm sure these are not guideline-directed therapies. These are very rare cases, so the studies for these types of interventions are limited. It's nice to present in case conferences, but
yes,
and I cannot give you
an exact value
for these types of patients.
Thank you. I think Dr. Yambao can help us with this question. How would you explain that to the patient, or like what body mass index is correlated with a lesser incidence of heart disease?
Actually, from the body weight's point of view, of course, the higher the BMI, the higher the risk for cardiovascular events. But that's not the only the risk factors affecting a patient's having a cardiovascular events. Of course, there are other risk factors that we need to address too. And there are also a lot of factors affecting BMI. Like, for example, a patients with increased muscle mass or increased bone density can have a higher BMI or compared to a patient who have a less body muscle mass and bone density. So it's really hard to really place or estimating the patient's cardiovascular risk with just using the patient's weight or BMI. So I think it should be taken as a whole, correlating the patient's other factors like other comorbidities and also endurance. A patient may have a higher BMI, but he can have a better endurance, can walk more, can climb stairs more, as compared with the patients with the lower BMI but has a poor cardiac capacity. Between the two, the ones with a higher endurance have a less chance of having a cardiovascular event. So let's not just focus on the weight, although it's very important also, but let's not forget that other risk factors also do play a major role in patients that are having whether to have a cardiac event or not.
Thank you, Dr. Yambao. Is there a role? Here's another question. Is there a role of antibiotics in patients with myocarditis?
Based on recommendations, definitely there's no role for antibiotics, but antivirals do have a role once there is a diagnosis-specific etiology is identified. And usually you can only achieve that by doing a biopsy. Which is really rarely done in our setting. So that's the recommendation based on guidelines to give antiviral based on the specific virus detected in the biopsy. But for antibiotics, none. Unless patients have a concomitant bacterial infection, which is also common in patients with viral cardiomyopathy.
Yes, it's true. We rarely do the myocardial biopsy in our local setting. Thank you, doctor. For patients who have undergone a PCI, how soon can they undergo another surgery?
That depends. Of course, that depends on the need for the surgery. We rather would like to delay the surgery if it's not very urgent. If it's an elective one, we prefer that the patients be maintained on dual antiplatelet for a year before we can safely reduce the need for dual antiplatelet therapy. So as much as we can, we must delay the elective surgery. But if it's an emergency surgery, that makes our lives more difficult because you'll have to remove your antiplatelets. So that poses or potentiates the risk for these types of patients. Of course, if it's really an emergency, like a vehicular accident, patient has to undergo an abdominal surgery with high risk of bleeding, then you have no choice but to discontinue your antiplatelet therapy. But for elective surgery, we prefer those surgeries be delayed for a year, not unless there'll be other indications for that need.
Thank you, doctor. I'll ask one last question. Someone said that they work in an HIV treatment facility, and they were asking if there's a heart-related comorbidity for those who have HIV, or could it be related to our topics for today, myocarditis and acute coronary syndrome, if you just have HIV as your risk factor?
Viral cardiomyopathy might be present with HIV, but for ACS, again, thrombosis, high cholesterol, all related to the antiretroviral. So I've treated a few patients with ACS, and they both have STEMI. They're very young patients, and their only risk is high cholesterol because antiretroviral treatment may predispose them to having increase in atherosclerosis because of the hyperlipidemia effect of the antiretroviral treatment. But we successfully intervened and did PCI in these two cases. And so far, for maybe at least 5-6 years now, they're very stable. We just had to continue the antiplatelet therapy and statins in these patients. They were not diabetic, they were not hypertensive. The only risk factor is the presence of the antiretroviral therapy. But for viral myocarditis, I think Ed will have his say regarding this.
Actually, for viral myocarditis, HIV can also be a risk factor, again, by affecting the host immune complex reaction. So patients with HIV are also at risk for having myocarditis.
Yes, and to add to that, Ed, actually, I have a few cases now admitted at the hospital who have viral myocarditis. But these cases, we rarely see these cases now because of the effectivity of the antiretroviral treatment that the patients are receiving now. But I noticed that these patients who never seek treatment with antiretroviral, they often present at the ER and they present with heart failure symptoms before they were diagnosed as having HIV. So that means that the antiretroviral treatment has really changed the game, or has really changed the management, the way we manage HIV patients, and our patients have really benefited from it because patients on antiretroviral treatment have rarely rarely have the myocarditis, except for some who denied getting treatment or wasn't able to get treatment.
All right. Thank you very much. It was nice to meet you and interact with you, Dr. Jefrey De Jesus and Dr. Eduardo Yambao.